basic question है. My father was a diabetic, my mother was not, but my nana was a diabetic, my dadaji was a diabetic, and among the taujis and chachas, they were diabetic. But I was very careful right from my childhood and KG, in the sense that I have to avoid this kind of issue in my life. And I was very successful till the age of about 51. In the sense, from the age of 30, consciously I started cutting down the amount of sugar that I was taking in my milk or in my, I was not much of a tea drinker. Till by the time I was 40 plus, it was just naam matra ke liye 4-5 grains of sugar just for a mental attitude. What triggered my diabetes, which I don't know why I'm saying a trigger word, because my mother was never a diabetic, but then she was admitted to a hospital at the age of 75 or something. She went through a long hospitalization. It got triggered, the diabetes. So what triggered my diabetes, there must be many triggers in people's lives, was that my sister-in-law, she developed cancer. And we were struggling. So this is when 9/11 happened. I was there in Chennai, because he stays in Chennai. So the stress of the 9/11, plus we realized that the end is coming. So I was more bothered about post her scenario, what is going to happen. Because the children were still in school, college, and not settled at all. And the way my brother has a very active lifestyle, because he had businesses and he used to travel hugely all over South. So that probably got me worried, because I am a very, very family oriented person and show my concern and everything for everybody and go out of my way to help people. So could you throw some light on this? Is there something called a trigger that happens, or it was silent for some time and just became active?
I think it's one of the most intelligent perception I've come across, that how diabetes has been caused to me at 51 years of age.
Just to add, I'm a very active sportsman. Right from the age of 8, I've made it a point, like today also, Naman was with me. I played my game of badminton, 1 hour of badminton, then come in.
That's wonderful to hear. I think, first of all, let me clear, whenever we're talking of diabetes of this kind, we are talking about type 2 diabetes. It previously was called adult onset diabetes. Let's be very clear, it is not type 1 diabetes which happens in childhood. So in general, because 95% of the diabetes in our country is type 2 diabetes. So what we are referring to here again and again is type 2 diabetes. Okay, now coming to what caused diabetes in your case, when you told me your history, you have a very strong family history. Parental side had diabetes, even your maternal side,
yes,
third generation
Nana
had
was
diabetes.
very, very
So you already were always in a very high risk category.
Okay.
Because when we see what causes diabetes, we need to look at the risk factors.
Okay.
And one of the biggest risk factors is the family history of diabetes with one parent or two parents. Second risk factor is people who are not into exercise or sedentary lifestyle. So, but you said you've been very active. So you virtually have been posing to me as a very good role model for what primary prevention is. That's what we say, the primary preventive measures can prevent a person who is at high risk or a pre-diabetic to getting into a frank diabetes. And that's what you did. Normally, otherwise in India, the diabetes manifests between 3 to 4 decades of life, 30 to 40 years of life. And you didn't get it till 51 years of age to become a frank diabetes. That was the time your primary preventive measure that you did diet control, you had active physical exercise, despite being already a genetic predisposition. So diabetes, coming to your question, that was it a triggering factor, or that you were a diabetic, you could only delay it. You were a diabetic because you had a genetic predisposition.
Okay, sir.
So diabetes is caused by basically two things. One is that you have insulin resistance. That is, the insulin being produced by your pancreas is not able to work the way it should have been worked. The tissues are not responding to that. The second is insulin deficiency. So in type,
these are two different things, insulin resistance and insulin deficiency.
Absolutely different things. And every individual
and both will cause diabetes.
Yes, it is said that type 2 diabetes, everybody is going to have predominantly insulin resistant and some amount of insulin deficiency for sure.
Okay.
And it is believed once a diabetes is diagnosed with frank diabetes by a diagnostic criteria, he's already lost 50% of his insulin secretion.
Okay.
So by the time you become diabetic at 51 years old, your secretion had come down to 50%. So that is why I became a frank diabetic. There are reasons to develop insulin resistance, there are reasons to develop insulin deficiency. Insulin resistance is mainly acquired because of sedentary lifestyle, high carbohydrate diet, when you are doing fetal malnutrition, and so many other reasons are there. And sometimes it can be because of the genetic predisposition. Obesity syndrome, people are obese, otherwise everybody in the family is obese. They can't help, they have insulin resistance, despite their all physical exercise and so that's the reason to develop insulin resistance. And insulin deficiency predominantly genetic. People who have some autoimmune disorder with the pancreas, their pancreas is not producing insulin. Majority of them fall into type 1, but few in type 2 as well. And sometimes it is acquired because of some viral infection, toxic infection, the pancreas starts producing less insulin. So there's a typical model that you are genetically predisposed person, but environmental factors gradually, aging itself is a big environmental factor. With age, everybody's insulin production goes down. But you do not have, a normal person does not have insulin resistance, so he doesn't become insulin diabetic. So your case was typically a very good model for primary prevention. Otherwise, you would have become diabetic at 35, 40.
Thank you. Related to this, one question, Doctor. This is, I was consulting Dr. Amrish Mittal. And this is almost about what? Talking about 2008, 2009, 2008 maybe. So he said, I want to put you on insulin. So at that point of time, I used to play a lot of golf. Every day I was golfing for about 4-5 hours, in the sense that in a week I was golfing 18 holes, which almost involved walking 8 to 10 kilometers. And 4 times a week, and 3 times a week I was playing 9 holes, or the vice versa. So 9 holes meant about 4 to 5 kilometers of walk. So that is one thing I've kept up in my life. I've never been obese. I've always been kind of my right weight, anywhere about 64 kilos to 68, 69 kilos, which is ideal as per my height. So I was very, in one of your WhatsApp messages, you said don't be resistant to taking insulin injections. So I had this huge issue that I would be on the golf course, and if I start getting insulin dependent on those injections, then I have to vary my lifestyle in the sense that I have to have either carry my breakfast or pause my game and have my breakfast, because all my games are played in the morning. So then I went back to this role model of this fast bowler of Pakistan, Wasim Akram, who was, I think, type 1 diabetic from his earliest childhood. And literally I should see him doing everything, and then suddenly he would sweat so much that he had to go to the dressing room, or some support had to be brought to him on the field. So I didn't want to get into that kind of a situation, because of course, being a diabetic, I have gone through those stages when suddenly your blood sugar has variated so much that either you're going into hypoglycemia or hypoglycemia. Both states I've gone through. So could you throw some light on this, that as an insulin taking injection person, a sportsman who leads an active life, like even today I'm leading an active life at work, so the meal can be delayed. I avoid 99%, but still beyond your control it does happen, and you tend to go towards that state. So what can be done, and what is your advice to such a patient who, because you said ultimately you will have to get to injection insulin at some stage of your life, as a diabetic?
I think that's the fundamental which every diabetic needs to understand. That, as I already said, insulin resistance tends to plateau in your life.
Okay.
Gradually insulin resistance is increasing, your diabetes is increasing from 1 drug, 2 drug, 3 drug, you're going, and insulin deficiency also increases with age. Insulin resistance tends to plateau with age, but insulin deficiency keeps growing with your age.
Okay.
Even a normal person who is not diabetic, his insulin production because the cells get tired out, fatigued out, the production goes down. So with expectancy of life going up and up, people living to 80, 90, 100 years, it is bound that every diabetic will later in his diabetic life will need insulin. See, what is the indication for insulin usage in a type 2 diabetic?
You're talking about injecting insulin.
Insulin is injectable.
Right, because what we take in Glimpride or the other.
Those are oral hypoglycemic agents. They are not insulin.
They are not insulin.
They act in a different manner altogether.
Okay.
They
I didn't know this.
I
didn't know. That's what they call insulin supplements. That's what I know.
There are sulfonylurea drugs which increase, which stimulate stimulate the pancreas to pump a little more insulin.
Okay.
The drug which you utilize.
Okay, but they are not insulin.
Yeah, absolutely nothing to do with
Okay.
insulin.
This was a huge misconception that I had.
Insulin production is a hormone which is produced by the pancreas, the beta cells of the pancreas, which is not available in any oral form as on date today. It has to be an injectable insulin.
Okay.
Of course, there are wide varieties of remodeled and newer insulin, but all are injectable today. There are some experimental work going on for oral insulin and buccal sprays and nasal sprays, but practically we are talking about injectable insulin. So what is the indication why a doctor says that you need insulin is in a type 2 diabetes with 20 years of diabetes or 30 years of diabetes, OHA failure, oral hypoglycemic agents have failed to produce the target control. So let us realize whether on insulin or not on insulin is not important. What is important for every diabetic is to have a target control. What he is going to get complications of diabetes is not because whether he is using insulin or not insulin, because his controls are not tight. So whenever we're talking of diabetes management, objective is to avoid or delay the complications, delay the mortality and morbidity because associated with the diabetes. That can only be achieved if you have tight control. If the oral agents are not able to produce tight control because the insulin deficiency is so much, the option left with the treating physician and the patient is to start this. So that is why I always said when insulin is necessary, it is necessary. Whatever the difficulties and whatever the problems you encounter, whether Wasim Akram was encountering, whether you have to carry your food, you have to go to a party, go to the washroom and take an insulin injection, all done.
You have to modify your lifestyle.
Lifestyle will help to a certain extent. That's what I'm saying. Lifestyle has failed, your oral agents have failed, sugar is not under control.
Okay.
What do? You have to use it.
Okay. So could you throw some light on these patches, etc., that they are talking, that they will secrete the required insulin,
just like the pumps, insulin pumps.
Okay. So what are I have no knowledge, or I think most of us don't have any knowledge.
It's a technological advancement in the mode of administration of insulin.
Okay.
The drug remains the same. The mechanism of action remains the same. It is only a mode of administering it. It is a computerized based machine which identifies how much insulin needs to be released at that particular time. And that releases from the pump the same amount of insulin.
Okay.
So you don't have to titrate yourself.
Okay.
You don't have to bother that you've done little 5 kilometers of walk. The body will need more less insulin. But I have taken full dose. I am getting to hypoglycemia. That is not true. You will take less insulin because you've already done 5 kilometers.
Okay. So which is what you wear it on
your
stomach?
It is
on the
over
the pancreas?
Abdominal wall.
There
is a small cannula which goes inside the skin.
Okay. So that is the kind of thing that is there permanently.
Totally.
And how expensive is it? Is it available in India?
It is available. It is free level.
Okay. And how expensive is it?
I don't know what you call expensive as.
No, I'm saying cost-wise.
There are models which are available from Western world which are very expensive. The Indian models also available.
Okay.
But then you're a little worried because the efficacy and the efficiency to release the right amount of insulin is paramount important. Because if they release a little extra insulin and you're going to hypoglycemia, so that's the issue. They're running thousands.
Okay. And sir, could you throw some light, because my father was a diabetic, so almost I think about 10-15 years, because he developed diabetes at the age of about 40-41, what you were saying. Then of course we were trying to control it with oral this thing, but I think once he crossed his 60, he lived to the age of 77. So last 15-16 years of his life, we used to boil that syringe, because in those days the disposable syringes were not there. This is, I'm talking about the 70s and the 80s. Finally died in 94. Around late 70s, you could say, we started this injection of the insulin. So since I was working with him, so I used to closely monitor him into his state, because we worked in the same office, we were doing business together. So I used to inject that insulin. Now in those days, if I remember, there used to be 2 vials that they used to give. One was a instant insulin kind of thing, and one was a delayed insulin. So we used to have I think it's called long distance, long lasting or something.
Yeah.
So we used to make a mixture of those dosage, and we used to give it to him. So what I wanted to ask was that on that insulin pack, it was mentioned that this is an animal insulin, and then later it came as a human insulin. So could you throw some light on the production of the insulin, what is it and how do you produce it, or how do you gather it, or how do you, is it chemically made? This is what I wanted to ask you.
We have today, I think, a lot of advancement in the quality and of the insulin has taken place. I do not know, I can't tell you how it has progressed from time what you're talking about is in 60s, 70s.
This is 70s and 80s.
70s and 80s.
And early 90s.
Now we have,
and those medicines used to come from abroad. Yeah. They were not being made here in India.
Must have been analogs. Otherwise,
yeah, analogs.
Analogs are much purified insulins.
Okay.
I mean, that's too academic, but they are highly purified insulin which do not have the amino acid. Insulin is basically 2 chains of amino acid. It's a peptide protein. So they're highly purified, and nowadays we do not use plain insulin and longer acting insulin, taking them in syringe and mixing them. We have n number of combinations which have, we call them pre-mixed insulins, and which have 30-70 component and 50-50 component. You see the brand which have 50-50.
So this is basically prescribed by the physician?
This is the domain of the treating doctor to decide, depending upon whether his sugar is high in the morning and high post meal or high in the night. So accordingly he decides the timing and duration and the strength of the insulin. So we have a number of insulin preparations which are human insulin, which are far better than bovine insulin, which was taken out for animals. And now we have analogs, which are synthetically prepared and far superior. And we have now, you don't have to boil syringes, you have ready-made pens, which have a cartridge in it, and there's a titrating, rotating device in which you can titrate accordingly. You 12 units, bring it to 12, shove it in, and you get 12 units of mixed combination insulin, plain as well as longer acting. Basal, there are plain available individually also which should be used as a basal insulin at night time. You know, there are different regimes, and a patient is put on insulin. It does not mean that he'll have to be totally on insulin all through the day. There are regimes which patient can be managed with nighttime insulin, with daytime sulfonylurea, we call it BIDS, basal insulin, and daytime sulfonylurea. Or some people have to be taking with every meal. So which insulin, whether a shorter acting or a longer acting or an intermediate acting or a combination of two have to be is to be decided by the patient according to the patient.
Okay, when you say human insulin, so it is what, drawn from a human body or something?
No, not from human body. It is very near to the one which is produced in our body.
Okay. So one question, again, it may be a personal question, but I think it may be hugely relevant to other people. In my case, what I have found is that my what you call the fasting sugar is always more than the postprandial sugar. The sugar after the meals. Now, he's increased my dosage in the night and the lesser doses in the daytime. But then what I find personally in life, that if I don't keep my sugar levels at about 160 or something, if my sugar levels drop below 120, I can feel it, 110 or so, 100, I start going into the hypoglycemic stage. And I get very confused, I can't perform. If I'm on a golf course or if I'm playing a game, then like what shot should I take or what club should I pick up? The confusion starts setting in. Or suddenly I start feeling very, very jittery.
Yeah.
So is this a very common phenomenon?
It's a very common phenomenon. The two things which needs to be stressed here is, one, the targets of diet control are different in different age groups and different in the people depending upon their physical activity. If a 40-year-old person says that when I'm controlling a diabetes of a 40-45-year-old person, an executive in an office, hardly any physical exercise, my aim would be to make sure his fasting sugar is less than 120, 25, 130, and postprandial is never more than 180. But a person, 80-year-old, paradoxically very physically active, my targets would change.
Okay.
I would like to keep him fasting below 150, 140, and postprandial below 200. That's okay with me.
Okay.
HbA1c of 7.
Thank you, sir. That's a huge.
That's very clearly.
No, I don't know, but
it's all
the treating doctors do not. They should be very rigorous that no, you must come to 80, 120, and
that's what I'm saying.
So one of my cousins, in fact, who was a teacher in Sriram College of Commerce, he lost an eye because of this, because he was constantly very happy that he was keeping his blood sugars around 120, 80, And he lost.
Today we are in an era where we are practicing all evidence-based medicine. What I am saying is not mine. It is all in the documentation by American Diabetic Association, International Diabetic Federation,
Excellent to hear that.
WHO or ICMR. So the guidelines have said that the targets need to be relaxed in a person with
it varies from person to person.
Yes. So
Very good
the
to hear that.
HbA1c is 7.5, not 7 for you. For me it may be 6.5, 7, but for a person with 80 years, 7.5.
Okay.
And similarly, when we say hypoglycemia, the standard textbook says hypoglycemia when the sugar falls below 50, 60, or the 40 के नीचे unconscious हो जाएगा. But n number of times in my clinical practice, I encounter patients saying that जिस दिन मेरा 100 से भी नीचे जाता है, I feel a little confused. I am not oriented to.
Correct.
So that's a warning for me to change the targets.
Okay.
I would like to keep him in 120, 130, not even 100.
Okay, great.
Because
Great
human
to
body
know
is
that.
different, and Indian, the US and Western, what is written in the books is Indian perspective is much different. So the targets have to be different. And if you are feeling hypoglycemic features, confusion, you do not know which club to be picked up. So that's very clear that you need to be monitored at 120 to 160.
Okay.
Not 100 ever.
Thank you so much.
Very good.
Thank you so much. I think it would be
Maybe,
better.
I think this is good to break.